Okay, so because of a 10th nerve lesion, which is a vagus nerve, it was pulling the this uvula away from the side of lesion. So you will have a deviation of the uvula, which is away from the side of lesion. Okay. For the 11th nerve damage, okay, which is your accessory spinal nerve, okay, it supplies a trapezius, and that causes a shoulder drop on the side of the lesion because of the loss of trapezius, right? Then you have the 12th nerve damage, okay, which is pushing the towards away from each other, right? So whenever the damage of this 12th nerve happen, you will have a deviation of the tongue, which is towards the side of lesion, just like my jaw. So jaw and the tongue towards, okay, uvula away, okay, and shoulder on the same side, okay. Any doubt on these lesions?
No, thank you.
I honestly don't understand 10.
Which part?
Like, I don't understand why it's collapsing to the weak side.
The tongue.
Yeah.
Okay, see, just like my jaw, you have the tongue also supplying by the 12th nerve, right? If this
Yeah.
is your tongue, the tongue, the nerve on the right side, okay, it is pushing the tongue towards the left side, okay, while protruding the tongue, okay, and the nerve, which is on the left side, it is pushing the tongue towards the right side on the protrusion, okay. So if this nerve dies left-sided, then on the protrusion, you will be having a deviation of the tongue towards the side of lesion, right?
Okay, because you can't you can't push it to the other side.
Yeah, exactly. Because of a loss of this pushing from the left side towards the right side, I'm having a deviation on the this left side. Okay,
Okay.
that's why. Just like my jaw, in case of my jaw also, okay, the this fifth nerve or the mandibular nerve that is on the right side, it is pushing the jaw on the left side, and the mandibular nerve on the left side pushing the jaw on the right side. So in case of damage uh, in my left nerve, I will having a jaw deviation on the left side, right, the ipsilateral side. While in case of my uvula, both these nerve will be pulling the uvula towards each other, right? So in a scenario where any of my nerve dies, I will have a deviation or the pulling of the uvula away from the side of lesion. Okay.
Okay, so all of these are going to, oh no, that's not going to work. Okay, cool. These are individual. Thank you.
Okay. Then you have the facial nerve lesions. For that, first you have to understand the nucleus of the facial nerve. I told you that the facial nerve nucleus present in what part of my brainstem?
Pons.
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 Yes. Before the
Laterally.
pons. Yeah, exactly. Before the pons, if this is my pons, before the pons, I have the cortex supplying, to the pons. It is because all this primary motor cortex, it is present in my this forebrain, right?
Yes.
So the fibers from the primary motor cortex, it will be running down and supplying my pons. And these fibers are known as the upper motor neuron fibers, right? So they came and reaches the pons at the nucleus of my seventh nerve. And from the seventh nerve, from the nucleus of my seventh nerve, the real facial nerve originates that contain both all these fibers that are running from here. Okay, and because this brainstem has also its functions with the facial nerve, right? So all the senses from the brainstem itself supplied by the facial nerve, as well as all these inputs from my cortex, it will also supplied by the facial nerve. Are you getting my point?
Yeah.
Now the function of my cortex is to supply the lower part of my jaw only. Okay.
Yes.
Now what happens? Both my cortex, as you can see, both my cortex are supplying the nucleus of my facial nerve. Okay. And they both supplies the lower part. Okay. The cortex on the opposite side, on the contralateral side, okay, it is also supplying my, this nucleus, okay, for this upper part, okay, and the ipsilateral side of cortex is also supplying the upper motor neurons for the upper part of my face. So the lower part of my face, as you can see, it is only supplied by the contralateral cortex, and both the contralateral cortex and the ipsilateral cortex supplying the upper part of my face.
Yes.
Yes.
In a scenario, if you're having a damage in the cortex, okay, for say any infarction that involves my motor cortex, and let's say what kind of infarction can cause a damage to my face? What nerve? Oh, sorry, what artery infarction? Occlusion?
Middle cerebral. Middle cerebral.
Middle cerebral
palsy.
artery. Yeah, exactly. In a scenario of a middle cerebral artery, okay, in a scenario of the middle cerebral artery, I will have a damage of the nerve fibers running from this cortex, let's say, right? And if that happens, I will have a loss of supply to the lower face, but because my upper face is supplied by both the cortex, okay, the motor supply of the upper face will remain same, normal, right?
Yes.
Yeah.
So I will have only the paralysis of the lower face, or I can say the 1/4, the lower 1/4 of my face. While in the case, if I have a direct nerve damage, after this nerve is originated from my nucleus, from the brainstem, from the pons, if the damage happens, both the fibers supplying the upper face and the lower face will die.
Yeah.
Yes.
And in that scenario, I will have the loss of all the this muscle on the unilateral side of my face. Is that okay?
Yes.
Yes.
So this is a difference between the upper motor neuron lesion of my seventh nerve and the lower motor neuron lesion of my seventh nerve. Now the Bell's palsy occur because of a lower motor neuron damage of my facial nerve. Okay, at that point. Okay, and because of that, as you can see, I'm having all this muscle loss on the unilateral side of my face. Okay, causes includes the HSV reactivation. Okay, and the cause includes the Lyme's disease. If you guys remember, what bacteria can cause Lyme's disease?
Borrelia burgdorferi.
Borrelia burgdorferi, right? So the Lyme's disease can cause it. Herpes virus, this reactivation syndrome can cause it. Okay, sarcoidosis can cause it. Tumors can cause it. Okay, and if you guys remember about the parietal gland, whenever you have a malignant tumor of the parietal gland, it can also involve the facial nerve, right? It will compress the facial nerve, and that causes the facial nerve palsy, the Bell's palsy, right?
Right.
So these are the causes which can cause the unilateral loss of all these muscles. Okay, so you will have an asymmetric kind of a smile. Okay, and does my patient can close the eyes if I have a loss of facial nerve?
No.
No, because the closing of my eye is done by the facial nerve and the opening is done by the third nerve, right?
Yes.
Yeah.
So they will have inability to close the eye. They will have an asymmetric kind of a smile. They will have all the loss of wrinkles on one side of the face, right? And they also have this, yeah, that would be everything on the Bell's palsy. Now, what happens if I got the upper motor neuron lesion, or what happens if I got the lower motor neuron lesion? In the upper motor neuron lesion, because both of my motor cortex are supplying, okay, to the pons, I will have only the loss of all these muscles on the lower 1/4 of my face, okay, and it would be a contralateral, okay. Lower muscles of the facial expressions will die. You will have, the forehead involvement is not present, okay, because of the bilateral upper motor neuron innervation. Other symptoms are not present. In case of my lower motor neuron lesion, okay, that can be happen in the facial nerve, okay, after it originates from my nucleus. So if my nucleus dies, that means if my pons dies, okay, or if my nerve dies after the pons, you can have a lower motor neuron lesion, okay. Affected side will be ipsilateral, as you can see. In case of my brain damage, you're having a contralateral involvement, right? In case of my nerve damage, it will be a ipsilateral lesion. So that's why whenever you have the primary motor cortex damage, you will always have a contralateral face symptoms, right?
Yes.
And similarly, if you guys remember the pure motor stroke, remember the pure motor stroke, when can you get that?
Internal capsule.
Internal capsule, because of lengthostriate vessels. And I told you it would be a contralateral region, right? Involving all your lower limb, upper limb, as well as the face. Right?
Yes.
Yes.
So whenever you have the upper motor neuron lesion, it will be always a contralateral symptoms. Whenever you have a lower motor neuron lesion, it will be a ipsilateral kind of a symptoms. Okay.
Yes.
Now, secondly, yeah, that would be this. And both, if you have a lower motor neuron lesion, because now this facial nerve cannot supply the upper part of the face and the lower part of face, you will have a loss of both the upper face as well as the lower face innervations. Okay. And because I told you already that this nerve is also involved in the ears, right? To dampen the sounds, right?
Yes.
Yes.
Because of loss of the innervation to my ears, patient can have a hyperacusis, in which you have an increased sensitivity to the everyday sound. Okay.
Yes.
This symptom will be there. Loss of lacrimation will be there, right? Loss of salivation. And which glands are affected because of my facial nerve?
Submandibular and sublingual.
And what about my parotid?
It's not
Parotid
involved.
gland.
And what now innervates my parotid?
Vagus.
Vagus.
Ninth
Yeah.
nerve.
Glossopharyngeal.
Sure, glossopharyngeal. Of course, you must be sure it is glossopharyngeal, ninth nerve, right?
Yeah.
So the parotid gland, ninth nerve, the glossopharyngeal, and for my submandibular and sublingual, it would be my facial nerve. Okay.
Yeah.
Good. So I will have a loss of lacrimation. I will have a loss of salivation. I will have a hyperacusis. I'm having an incomplete closure of my eyes, dry eyes, ulcerations. All these things will be there in case of my lower motor neuron lesion. When I have the upper motor neuron lesion, I'm having just a paralysis of my lower face. Okay, my upper face, my eyes, my lacrimation, everything will be spared. Right? So that's about my upper motor neuron lesion and the lower motor neuron lesion of the facial nerve. Any doubt, please ask.
Why
No.
does sarcoidosis is causing the facial nerve lesion?
Because in case of my sarcoidosis, I'm having a granuloma throughout my body, right? If the granuloma involves my facial nerve, they can cause a damage to that also.
Oh, okay. Thank you.
Sarcoidosis can involve any part of the body. If you're having a neurosarcoidosis, it can involve the pituitary gland. And if you guys remember, if the pituitary stalk get damaged because of my sarcoidosis, I will get a
Diabetes insipidus.
okay. And any other important thing?
Sheehan?
Not the Sheehan syndrome is not that. The pituitary stalk damage. We're just connecting my hypothalamus with the pituitary. If that got damaged, I told you that you will get the hypopituitarism, but for one hormone you will get the increased secretion. What was
Prolactin.
that?
Prolactin.
Prolactin.
Yeah, you will get the hyperprolactinemia, and rest in all the hormones you will get the hypopituitarism, right? So just like that, sarcoidosis can affect any part of your body, anything you can imagine, it can do that. Okay, uveitis, arthritis, skin rash, and all these things. The skin nodules it can form, lung involvement, these glands involvement everywhere. It can mimic anything. Okay.
Yes.
How diabetes?
That yes.
How diabetes causing facial?
Sorry, I couldn't hear you.
How diabetes mellitus is causing facial nerve lesions like that, the facial palsy.
How diabetes mellitus can causing the
This facial nerve damage.
diabetes mellitus? See, in case of diabetes, you're having the neuropathies, right? Because of loss of blood supply to the nerves, and because of this glycosylation of the proteins.
So it should be it should be like generalized, no, not like only on facial or something like,
Yeah,
because there will
yeah,
yeah.
it should be generalized, of course. You will have the
So,
peripheral neuropathies also along with this facial nerve lesions again.
so it could be anywhere, any side, like.
Yeah, exactly. It could be anywhere, any side. Okay, so we are done with the neurology. Okay, and now we are about to start the otology. Okay. Okay, so your ear is divided. Any doubt on the previous page? Again, please ask.
No, thank you.
Okay, so your ear is divided into three parts. You have the outer ear, you have the middle ear, and you have the inner ear. The outer ear is the visible portion. You call it a pinna. Okay, and it transfers the sound to your middle ear, of course. In the middle ear, you have three bones: the malleus, incus, and stapes. Okay, and the ossicles will conduct the traveling of these vibrations from this external ear or the outer ear to the inner ear. It is an air-filled space. Okay, you must know that. Then you have the inner ear. Okay, it is having some snail shape. It is fluid filled. It contains the cochlea. Okay, where your specialized fibers, hair fibers are present. Okay, and whenever these hair fibers move, they will cause generation of the impulses for the sound waves, right? They will vibrate secondary to sound waves, and that will generate the auditory nerve signaling, right? Now, you must know that on the apex of this cochlea, okay, on the apex, you're having a low frequency sounds, and on the base, you're having a high frequency sound. So whenever the base of the cochlea get damaged, you cannot hear the high frequency sound. And whenever the apex of my cochlea damage, okay, which is near the helicotrema, you will have a loss of low frequency sound hearing. Is that okay?
Yes.
Okay. So that would be on this paragraph, nothing so much special. Then you have two tests for the diagnosis of the hearing loss. One is the Weber test and second is the Rene test. Before we come to that test, we need to know that two type of conduction to all these auditory impulses would be there. One is the bone conduction and second is the airway conduction. Okay, and this airway conduction, it is always more than the bone conduction. Are you getting my point?
Yeah.
Yes.
Now, in case of my this Rene test, I will check for the air conduction and the bone conduction. Now, first of all, I will, I will make the patient hearing a tuning fork. Okay. First, I will touch this fork at the mastoid of my patient. Okay, and as a result, the vibrations will happen in the mastoid. Okay, the vibration will travel by the bone and reaches to my cochlea. Is that okay?
Yeah.
In case of my air conduction, as soon as this bone conduction inhibited, when the patient tell you that he no longer can hear the sound, okay, because of this vibration, you will immediately place this tuning fork near the ear and check for the air conduction. If he still can hear the vibration in the air, that means the patient is having a air conduction more than the bone conduction. That means it is a normal test, right?
Yes.
Yes.
Now, for the air conduction, you need a proper passage of the air of all these vibrations. That means you need a proper external ear, you need a proper eardrum, you need a proper ossicles as well as my cochlea, right? In case of my bone conduction, you don't need anything, just a bone. Okay.
Yes.
Yes.
Now, second test is my Weber's test. In that test, I will place the tuning fork over my skull at the apex, at the vertex, you can say. Okay, and then these vibrations will travel by the bone and reaches to my cochlea, and then they will vibrate. And my patient said that yes, they can hear the sound, and I will call it a normal Weber test. Okay, now see, in a scenario where I'm having a conductive hearing loss, okay, that means no vibrations or no sound can reach through the air. Okay, and it can happen because of a damage in my auditory canal. It can happen because of any fracture in my ossicles. It can happen because of a damage in my eardrum, right? But all these structures which are involved in the air conduction, if any of the structure got damaged, then I won't get the air conduction, right? And I will call it a conductive hearing loss because my all these structures cannot conduct the hearing, right?
Yes.
In that condition, if I perform the Rene test, I can easily get the bone conduction because I do not require anything, just the bones, right?
Yes.
So I will get a normal bone conduction. And when, as soon as my patient tell you, that he no longer can hear the sound, you will place a tuning fork near the ear, and he will again tell you that he cannot sense anything. That means the bone conduction was more than the air conduction, I can say.
Yes.
Will that make sense? Because because
Yes.
all these structures are get damaged, so you won't get the air conduction. So in my Rene's test, I will get the bone conduction more than the air conduction. Okay. But now see, because my bone conduction was absolutely normal, and in the affected ear, I'm not hearing anything from the air. But in my normal ear, I'm hearing things from the ear, from the air also, and from the bone also, right? So if you place a tuning fork over the vertex, I will have the localization of all these vibrations on the affected ear, because only the bone vibrations can reach there, right? But on the normal side, I will have the conduction both from the air, so all these sounds will be entering through the air also and through the bones also, right? But on the affected side, I can have the sound entering only from this bone side, right? Not from the air.
Yeah.
So because my normal ear has to perform multiple functions, but this affected ear has to perform only one function, right? So it would be a localization on the affected side on the Weber's test.
Yes.
Yes.
So so whenever you encounter a patient who is having a high bone conduction but a low air conduction, that means something is causing a problem in the conduction pathway of the air, and you will have a localization on the affected side because the ear has to perform only one function on the affected side, but the normal side ear has to perform multiple functions, right? So localization will be on the affected side. You can hear more vibrations on the affected side, right? That was about the
Yes.
conductive hearing loss. Now, in case of my sensory neural hearing loss, because for both my air conduction as well as my bone conduction, you require the cochlea ultimately, right?
Yeah.
If you do not have the cochlea, then both the air conduction and the bone conduction will suffer,
Yes.
and the ratio will be same for both of these conductions.
Right.
In that case, I will have again a more air conduction than the bone conduction, because equally I'm having a loss of both these air conduction, the bone conduction, right?
Right.
Now, when I put the tuning fork on my vertex of the skull, okay, where can I have the localization?
Better ear.
Exactly, and the
Right.
battery, because on the abnormal ear, I cannot sense the bone conduction, I cannot sense the air conduction, but on the normal ear, I can sense both the air as well as the bone conduction. So the localization, or I can say I will hear more frequency, more vibration, okay, on the normal side, because the normal ear is normal and the affected ear cannot hear anything, right?
Yes.
So if you're having a high air conduction than the bone conduction and the localization is present, that means it is a sensory neural hearing loss. If you're having a bone conduction more than the air conduction, along with this localization on the ipsilateral side, that means you're having a conductive hearing loss. Okay.
Yes.
Okay.
So now any doubt on the diagnosis of the hearing losses?
No.
No,
Thank you.
thank you.
No. Now, after you made a diagnosis, now you need to know what causing the damage, right? So you have a types of hearing loss. One is the noise-induced hearing loss, and second is the presbycusis. Okay, in case of my noise-induced, because of this chronic exposure to the high-intensity noise, high-frequency noise, you will have a damage to the organ of corti. Okay, and because the damage first happened at the apex, you're having a loss of high-frequency sound first. Sorry, yeah, so because whenever the patient expose themselves to the high frequency sounds, okay, then the damage, because all these high frequency sound will be collecting at the base of my cochlea, right? And all the low frequency sound will be collecting at the apex of my cochlea. right? So because of this chronic exposure to the high frequency sound, you're having the damage to the base of the cochlea, and as a result you will have a loss of high frequency hearing first. Is that okay?
Yeah.
And does it a sensory neural hearing loss or a conductive hearing loss?
Sensory neural.
Sensory neural hearing loss. So you will get a normal Renner test but a abnormal Weber test. Okay. Now if a sudden this condition is the exposure whenever the exposure happens chronically. If we have a sudden exposure to the high frequency sound, extremely loud noises, then you will have a rupture of the tympanic membrane. Okay. And as a result, what kind of hearing loss you will get?
Conductive.
Conductive.
Conductive hearing loss. And does it a unilateral hearing loss or a bilateral one?
Can be any.
Can be any. But in case of this sudden type, you will generally have the bilateral loss. Okay, because both the ears will be exposed to the same loud noise, right?
Yeah.
So generally it is bilateral mostly. It can be unilateral, of course, but mostly it is bilateral. Whenever you have any auditory nerve damage, for example, that means a sensory neural hearing loss, it is generally unilateral. So that is another way by which you can differentiate between the this noise-induced hearing loss and a damage to the auditory nerve. Because in case of my noise-induced hearing loss, you're having a sensory neural hearing loss, right?
Yeah.
And in case of my auditory nerve damage, you're also having a sensory neural hearing loss. So in both the conditions, you need to then differentiate whether it is a auditory nerve damage or whether it is a damage to the organ of Corti, and that can be differentiated with the help of bilateral hearing loss or the unilateral hearing loss, because both the ears will be exposed to your high noise. So in case of my noise-induced hearing loss, you will get the bilateral mostly. In case of my auditory nerve damage, you will get the unilateral hearing loss. Okay.
Yeah.
And how does my auditory nerve can get damaged?
Schwannoma.
Schwannoma, yes. Okay. Now, second, you have the presbycusis, which is a age-related progressive. It could be bilateral. It could be a symmetric. You can say both terms, right? Sensory neural hearing loss, and that happens because of the high frequency sound, because of a destruction in the cochlear base, similar to my noise-induced hearing loss. Okay, whenever you expose your ears to a very loud noises, you will have a damage in both the ears, so the condition will be bilateral again. Okay, and the low frequency sounds will be preserved because they are present at the apex. Okay, so in the noise-induced or in the age-related hearing loss, you will have initially the high frequency and then the low frequency. Is that okay?
Yeah.
So that's about the type of hearing losses. The test you will choose for the hearing loss. Okay, and that's about your physiology of the ear. Any doubts so far?
No, thank you.
Then you have the cholesteatoma. Okay, and it is basically you have two types of otitis media, right? The acute and the chronic one. Okay,
Yeah.
and the cholesteatoma is a complication of the chronic otitis media. Okay, because of this chronic otitis media, because of this negative pressure inside your middle ear, you're having some formation of the pockets on the eardrum. See, you have this eardrum, okay, and then you have this inner ear, okay, you have this external ear, okay. With the chronic otitis media, you're having all this negative pressure inside my this ear, right? Okay, inside middle ear, I'm having a negative pressure. Because of my negative pressure, I'm having some formation of pocket structures on the inner side of my eardrum. Okay,
Yeah.
and when these pockets are formed, they will be filled by the squamous cell debris because it is an inflammation, and in the inflammation cell dies, they will become debris and they will start collecting in these pockets. Okay,
Yeah.
and when they start collecting in this pocket, they will form a mass behind my ear, behind my eardrum, and they will appear as the pearly mass. Very important. Okay, when you look in the ear with a torch or with a scope, you will see a pearly mass extending from the middle ear. Okay, rupturing your tympanic cavity. This membrane. Okay, and this will be a mass filled with the squamous cell debris. Now this mass is so much severe that it will also destroy your ear ossicles. It will destroy because of the inflammation. And you know that inflammation always causes the collateral damage, right? The nearby structures will get die also. And because this mass is nothing but a product of inflammation. So because of the recurrent inflammation, you will have a damage of the ear ossicles also, right?
Yeah.
Yes.
So what kind of a hearing loss you will get?
Conductive.
A
Conduction.
conductive type of hearing loss. Now, along with these ear ossicles, you have the mastoid ear cells also. And when they get damaged, this is a mastoid ear cells present on the upper part, they will get damaged. Okay, this inflammation can even reach to your brain, and that can cause the brain abscess also. Okay.
Yes.
Yes.
And that is the reason patient will die because of the cholesteatoma. This condition is often non-fatal, okay, but sometimes it becomes fatal whenever you have the brain abscess as a complication. It generally presents you with the painless otorrhea. Okay, you will have some kind of a protrusion mass coming out of the this tympanic membrane. You will have this conductive hearing loss. Patient will have the symptoms of the otitis media. They will have this ear pain. They will have a ear discharge. A chronic history will be there. Okay, so these are the things for the cholesteatoma. It is because of a negative pressure in the because you have this eustachian tube for the normalization of the blockage. This process, this pressure, right? And whenever this tube get blocked because of the infection or because of anything, you will get a negative pressure start building up inside the ear, right? And that will pull out all these uh, structures uh, in my tympanic membrane, and it forms a pocket which is filled by the inflammation products like the keratin debris. It will form a mass that will destroy the nearby structures like the ossicles because of the inflammation, the mastoid ear cells. Patient can have a conductive hearing loss. Patient can have the destruction of all this tympanic membrane, and a pearly kind of a mass will be coming out of my middle ear. That we will see on the examination of the patient. Any doubt on the cholesteatoma?
No, thank you.
No, thank you.
It is nothing but just a chronic otitis media. Okay. So yeah, if they ask you about this, please note it is not a tumor. Okay, although it has name OMA in it, it is not a tumor. It is just a mass formed by the debris of the squamous cells. Okay, and yeah, that would be all about it. Any doubt on this page?
No, thank you.
And does anyone know how to differentiate between the external otitis media and the the otitis externa and the otitis media?
Otitis media protrudent, eardrum, reddish.
Okay, in externa.
The earlobe pain.
Okay, well, that type of pain could be there.
Otorrhea.
Both otorrhea could be there in both of my media as well as externa. One thing is involvement of eardrum. You said it right. You will have the involvement of eardrum only in case of otitis media. It will be a bulging
Fluid
tympanic
behind.
membrane. Yeah.
Eardrum fluid behind.
Yeah, the eardrum will become very red, very inflamed. It will bulge and ultimately it will get rupture. And when it rupture, all the secretions which are present in my middle ear because of the inflammation, because of this infection, I will have a discharge of all these secretions, right? So I will have the otorrhea. In case of my otitis externa, I will have the inflammation only in my ear canal. My tympanic membrane will be exclusively normal. Okay, it has no symptom. All this discharge will be present in the external ear only, not coming from the internal ear or the middle ear, right? So that's how you will differentiate between the otitis externa and the otitis media. The involvement of this eardrum is important. If it is ruptured, if it is inflamed red, that means it is otitis media. If it is normal externally, okay, that means it is a otitis externa, right?
Yes.
And one of the otitis media is the cholesteatoma. So that would be all on this page. Then you have the nerve supply for the ear. Okay, most of the part is supplied by trigeminal nerve V3, and that's why you have this raphoid pain. And what does this raphoid pain known as?
Rhaphodotalgia.
Nephralgia, right? And yeah, you will also have, on the ear canal, you have three nerves actually. On the anterior side, okay, you have the presence of the trigeminal nerve again. I'm talking about the ear canal this time, okay? On the anterior wall of the ear canal, you have the mandibular nerve, okay, sensory impulses. On the posterior side, you have two nerves. One is the vagus and second is the facial. The major part is of vagus, and on some of the scattered parts, you have the facial nerve. So sometimes what happened on the examination of the ear, okay, in some patient, if you touch that part of this eardrum, sorry, this ear canal, the posterior part, patient will have the vasovagal syncope also. Okay.
Yes.
Okay.
So it could be a patient who is having a history of the ear pain, and while on the examination of the ear, okay, when the physician touches the posterior surface of the ear of this ear canal, the patient suddenly have the syncope, and they will ask you why the syncope happens. It is because of the vagus nerve. Okay, because it's the posterior part of your external ear canal, you will have a vasovagal syncope because of that after the stimulation of the posterior external ear canal by the otoscope or by the scapula. I mean this speculum. Okay, you will have a loss of heart rate, loss of blood pressure, and that causes the syncope. So please note, because it is supplied by the vagus nerve here. On the earlobe, you have the great auricular nerve. Okay, and the upper part you have the lesser occipital. So the main nerve will be your trigeminal nerve, facial nerve, and the vagus nerve. These three nerves you must remember. Okay. Now you have the vertigo. Okay, which is basically a triad. Could be it would be a dizziness. Okay, and you must distinct it with the lightheadedness. Okay, both are two different things. Okay, and yeah, it is basically a sensation of the spinning. Okay, while all the things are actually very much stationary. Okay, now you have two type of vertigo. One is the central vertigo and second is the peripheral vertigo. Okay, first let's discuss about the peripheral vertigo. Okay, now it could be due to the Meniere's disease. If you just forget it, let me tell you this. You must remember this algorithm. Okay, so you have actually four causes of the vertigo. Okay, one is the Meniere's disease. Second is the BPPV, which is the benign paroxysmal positional vertigo. Third is the vestibular neuritis, also known as the labyrinthitis. And fourth is the acoustic this neuroma, which is the schwannoma. Okay, these all four conditions can cause the vertigo. That means a dizziness. Okay, so you need to differentiate between these four conditions. Whenever you got a patient who is having a vertigo, you will need to differentiate between these four conditions. So let's discuss them. First, you have the Meniere's disease, and this condition you're having the increase in the volume of the endolymph. Okay, you have the endolymph formation, you have the drainage of the endolymph. Whenever the formation of endolymph is increased, or whenever the drainage of the endolymph is decreased, okay, you will have an increased volume of the endolymph. You call it an endolymphatic hydrops. Okay, and because of that, the patient will have a compression of the nerves. Okay, and this compression having this compression will be episodic. Okay, because initially you have this increased volume. Okay, then and then at the time the resolution of symptoms will occur, the volume will be decreased. You will get the some relief from the symptoms, and then again the same cycle repeats. You will have an increased volume, and then increase in the drainage will be there, and then again the increased volume, then the relaxation again. So the symptoms will be episodic. That is the first thing for the Meniere's disease. You will get the recurrent vertigo. Along with the vertigo, because it is a nerve compression, you will get the hearing loss also. Okay, you will have a ear fullness, pain, and the tinnitus. Okay, so tinnitus, vertigo, hearing loss, and all symptoms are episodic. Think about the Meniere's disease, and that's because of an increase in the endolymphatic this volume, and as a result, the pressure inside my ear will be increased. That will compress the nerve. That will cause the symptoms. Okay, when the pressure resolves, when it decreases, you will have the resolution from the symptoms. Okay, and then again the same cycle repeats. You will get an increase in the volume, and again the symptoms will be there. In the BPVV, it is because of the stones in the semicircular canals. and you call them the otoliths. Because of these otoliths, whenever you have the head movement, these stones will move and they will cause the vertigo. And that's why the name paroxysmal positional vertigo. Okay, so you have the dizziness with the head movement. Think about the BPVV. And please note, you have no auditory symptoms like the tinnitus or the hearing loss. You just have the vertigo, and that happens whenever you change the position. Okay, that will be happening in the BPVV. Then third, you have the vestibular neuritis. It is same as this BPVV. You have the loss of you only have the vertigo, no hearing loss will be there. Okay, but this condition, because it is an inflammatory condition, it happens only after the viral infection. So look for the recent history of any kind of a viral infection in case of labyrinthitis. It could be an upper respiratory tract infection, like just cough would be there, nasal congestion, nasal discharge would be there. It could be a case of otitis media. It could be a case of anything, right? Okay, anything in the upper respiratory tract. Whenever you get this, you will have the labyrinthitis. Okay, so for diagnosis of labyrinthitis, look for the recent viral infection, and now the patient is starting having the vertigo without any hearing loss. Okay, so BPPV, it is positional with the head movement. You have this, it is continuous, progressive kind. Okay, but it is self-limiting. It happens after the viral infection. Then just like my Meniere's disease, you have the acoustic neuroma in which you're having this tinnitus, vertigo, as well as the hearing loss. But in case of my acoustic neuroma, it will be progressive type. Symptoms are continuous, persistent, and progressive, not unlike my Meniere's disease where symptoms are episodic. So whenever you have a classical triad, the tinnitus, vertigo, hearing loss, which is episodic, think about the Meniere's disease. That means increasing the endolymph. Whenever you have a persistent and progressive symptoms, think about the acoustic neuroma. Whenever you have just the vertigo without any hearing loss, think about the BPVV or the labyrinthitis. If the patient having any history of a recent illness, think about the labyrinthitis. If the patient is having a vertigo with the head movement, think about the otoliths. Any doubt on the vertigo?
No, thank you.
Please remember this algorithm. Okay. First, see what symptoms patient is having. If it is having the classical triad, think about the Meniere's and the acoustic. If he's having just the vertigo, think about the BPPV or the vestibular neuritis. And that's everything mentioned here. For the central vertigo, you have the acoustic neuroma. That means it could be due to a damage in the cerebellum or could be a damage in the nerves. For the peripheral vertigo, you have this Meniere's disease, you have the BPPV, you have the labyrinthitis. Okay. And because this Meniere's disease is because of the endolymphatic volume increase, you have to restrict the salt diet and you have to give the patient diuretics as a treatment. Okay. And yeah, whenever you have the central vertigo, you're having an involvement of cerebellum also, you will get the dysmetria. Because of that, you cannot touch the nose with the finger, you will get a diplopia. Okay, you will get the misalignment of the eyes, and it will be a upward and downward type of misalignment, skew deviation you call it. It is a vertical misalignment. Okay, and yeah, that would be all the difference between the periphery and the central vertigo. So for central vertigo, you have the cerebellum lesions, you have the acoustic neuroma. For the peripheral one, you're having a Meniere's disease, you're having a vestibulitis, you have this BPVV. Any doubt?
Could you explain the difference between vertigo and lightheadedness?
See, in lightheadedness, it's like a syncope. You will have it very immediately, while just walking and then suddenly fall. In case of vertigo, you have first a spinning kind of sensation. Patient will tell you that they have this spinning sensations before falling. Okay.
Okay.
So lightheadedness is kind of very much rapid and you won't have any spinning. Okay. In case of this vertigo, you're having this spinning.
There's a difference between vertigo and dizziness, right? Vertigo, patient would say patient spinning, and versus dizziness, patient would say patient self-spinning.
Yeah. Okay. Any more doubt?
No, thank you.
Okay. Because sometimes you can confuse a vertigo with the syncope also. So you must know what kind of a history patient is having. That would be the important thing. Okay.
Yeah.
If it is very much quick, they don't remember anything, they're just standing and they suddenly fall. They don't know what happened to them. It would be like a syncope or a lightheadedness. Okay, if they know what's happening to them, like the spin sensations, sudden type, that means it would be the a vertigo, right? So that was about my otology. Any doubt on the otology?
No, thank you.
No, thank you.
Then let's discuss the ophthalmology. So first, the normal eye anatomy. I hope you everyone know you have in the center the lens. Okay, the lens will be extended with the zonular fibers, as you can see, which is attached with the ciliary bodies. Sorry, the ciliary muscles. And in the center of the ciliary muscles, you have the ciliary body. And what is the function of the ciliary body?
Secretion of aqueous humor.
Yeah, secretion of the aqueous humor. Okay, now from the lens to all this anterior part, you have the anterior segment. After the lens, you are having the posterior segment. In the anterior segment, you're having the aqueous humor. In the posterior segment, you're having the vitreous humor. Okay. Now, anterior to my lens, you have this iris. Okay, that covers the lens. Okay. In the central part of the iris, where the iris is not present, you call it the pupil. Okay. And finally, the last layer you have is the sclera and the cornea. Okay, this layer is the sclera, and in the center you're having this cornea, which is a transparent membrane. Okay, allow the passage of the lights. I think 60% of 60 or 70% of the light bending is done by the cornea, and rest of the light bending is done by the lens. Okay, so whenever you have this light coming here, like parallelly, you will first have the light bending from the cornea, and then you have the light bending from the lens. Okay, like that. So major of the light bending is done by the cornea only. Okay,
Yes.
now when the aqueous humor forms, it will travel for, this anterior segment is also divided into two parts, the anterior chamber and the posterior chamber. The part anterior to my iris is known as the anterior chamber, and the part posterior to my iris in front of my lens, it is known as the posterior chamber. When this aqueous humor forms, it will travel first in the posterior chamber, then it will travel into the anterior chamber, and finally it will be reabsorbed by the canal of Schlemm, or okay, or it could be a direct absorption by the this sclera, okay, by the episcleral vessels. Okay, and then finally you have this retina, which is nothing but just this optic nerve that forms a retina ultimately. Okay, and in the center of my optic nerve or the optic disc, you're having the central retinal vein supplying all the structures of my retina, right? So that's about the anatomy of my eye. Once you do the fundoscopy, okay, you're passing the lights from here to here, okay, and you're visualizing this part of my retina. Okay, so as you can see, this part is the optic disc. That means this part. Okay, this is the optic disc. You have the macula here, okay, somewhere here, and the central part of my macula is known as the fovea. Okay, this is my macula, and in the center you're having the fovea. Okay, these are the retinal veins and the arteries. That means these vessels. Okay, and yeah, that would be all on the fundoscopy findings, and this is the eye anatomy. Any doubt?
No, thank you.
So please note that all of the retina has a single supply from the central retinal vein and the artery, but this macula, it has dual blood supply. Okay,
Okay.
it has dual blood supply. That's all the part have only one blood vessel supply. Now you have the conjunctivitis, okay, which is the inflammation of the conjunctiva. Okay, you have this redness, as you can see. You have this redness in the eyes. It could be allergic. Okay, it could be because of the itching. Okay, it will be bilateral. It happens because of any kind of allergen, like the dust, okay, like the pollens, or like anything. So patient will have a itching in the eye. It will be bilateral. Along with the itching, they also have this kind of secretions in the eye also, watery secretions in the eye, like tears. Okay, so tears will be there, itching will be there. In case of bacterial conjunctivitis, okay, you will have the pus in the eyes. Okay, and it will be treated with the antibiotics. And does anyone know what kind of bacteria can cause the conjunctivitis? What bacteria can cause the conjunctivitis? We discussed that in the microbiology already.
Gonorrhea.
Gonorrhea, yeah, and
Chlamydia.
chlamydia, yes, gonorrhea and the chlamydia. Okay, as soon as the baby took the birth, okay, the most important cause of the conjunctivitis is the gonorrhea. After 10-12 days, okay, the most important cause is the chlamydia. Okay, whenever you have this first discharge from the eye, which is very much purulent, think about a gonorrheal conjunctivitis. Okay, whenever you have kind of a watery secretion, okay, after 10 days, think about the chlamydia. You can have a blindness with the neonatal the conjunctivitis with the gonorrhea, but you can't have the this blinding with the chlamydia. Okay,
Okay.
so as soon as the birth happened, think about the gonorrhea. After 10 days, think about the chlamydia. Okay, and any kind of a tear, even any kind of a secretion from the eye, even a tear, okay, it is always pathologic, because up to 1 month, okay, a baby cannot form the tears. Okay, even if they cry, they cannot form the tears up to 1 month. Only after 1 month the tear will be present in the neonate. Okay,
Yeah.
so before 1 month, if you have any kind of a secretion from the eye, even a tear, it could be due to conjunctivitis or any kind of this eye infection. Okay, very important. Then for the viral, you have mostly the adenoviruses. We have discussed that. Okay, other viruses, it could be the measles virus. Okay, HSV1 can cause the keratoconjunctivitis. Okay, it could be this condition could be also the autoimmune. Like if you guys remember the Sjogren syndrome, you're having the keratoconjunctivitis sicca, right?
Yes.
So all these causes can cause a red eye or the inflamed eye. You will also have this eye congestion in case of any bacterial infection. If anyone remember what kind of a bacterial infection can cause the eye congestion, redness without an inflammation.
Rett syndrome.
What? Come on, try. Eye congestion without any inflammation. Leptospira.
Okay.
Heard that name before?
Yes.
Thank God. So leptospira is belong to which group?
The curved bacteria. So the spiral bacteria.
And what you call them? Spiral bacterias?
Spirochetes.
Spirochetes.
Spirochete.
Yeah. And how can you cause a leptospira infection?
Water, rat pee in the water.
Animal urine. Yeah. Animal urine in the water, right? By doing the desegregation water activities. And the fatal form can even lead to the organ failure. Remember the renal failure, liver failure, you will get the shock, sepsis, right?
Yeah.
So don't forget the leptospira. Okay. Leptospira is another cause, but it cannot cause the conjunctivitis. It causes the symptoms like the conjunctivitis, but without any pain, without any itching, without any discharge, right? It's just a redness in the eye without any other symptom. Okay.
Yeah.
Okay. And you have the refractive errors. Okay. One is the hyperopia. It is also known as the farsightedness. Okay. And when the light focus behind the retina, okay, so the patient can see the far vision, okay, the far objects, but they cannot see the near objects. Okay.
Yeah.
And that happens because of decrease in the converging power of the lens, because the function of the lens is to converge the light, right? Whenever the lens fail to do so, the the light will be focused behind the retina, right? So so what happens if this is my lens and this is my retina? Okay, if the object is very far behind, okay, the light will be focused normally, right? They will focus on the retina. Okay, but if I bring the object closer, okay, then this light will travel, will be converged less, and as a result they will focus behind the retina. Okay, So as soon as I bring the object closer, the image will start forming behind the retina, and that's how I will get the hyperopia. Okay, that can also happen other than a lesion in my lens. It could be because of a damage to the corneal curvature, because I told you that cornea is involved in, I think, 60 or 70 part, 60 or 70% of the this conversion in the light, right?
Yes.
So if the converging power of my cornea change because of a change in the curvature of my cornea, you can again have the hyperopia. So lens and cornea both can do that. And how can you correct this condition?
Convex lens.
By giving the patient converging lens, right?
Convex.
Those lens which can converge the light, you need to give the patient convex lens. Okay, these will converge the light for my lens, right? So that's how we'll treat this condition. Second, you have the myopia. In this condition, you can see the objects which are closer to you, but cannot see the far behind objects. Why? Because the light is forming in front of my retina. Okay, if this is my lens and this is my retina, the light will be converging in front of the retina whenever you place the object far, whenever you place the object close, because as you keep the object closer to the eye, this image will start forming behind it, right? So it will focus at the retina ultimately. Okay, that happens because of increase in the converging power of my lens. That can be happen because of the cataract. Okay, it can happen because of increase in the curvature of my cornea. Okay, it can also happen because of a decrease in the size of my eyeball. Can I say that? If the size of my eyeball decreases, then the retina will be closer to the lens, right?
Yeah.
Yes.
In that case also, oh sorry, if the size of my eyeball increases, sorry, not a decreases, if the size of my eyeball increases, then the retina will go away from my lens. And if this was a normal position where my lens was focusing the light, so lens will still focus the light here, but the retina is now shifted behind because of the increase in the eyeball size.
Yeah.
Right? So that can also cause some myopia. And similarly, if the size of my eyeball decreases, I can have the hyperopia.
Yeah.
Okay, so do remember that. Then you have the astigmatism, and that happens because of this abnormal curvature of my cornea. Okay, you will have a different refractive powers at different curvature. Okay, so two different images will form. Okay, images will be formed at different axes. Different images will form, so patient will have the diplopia most commonly. Okay, and you call it the astigmatism. It will be corrected with the cylindrical lens. Okay, now see, if there's a patient, okay, just give me a second. Okay, yeah. So we're done with the astigmatism, right? Now let's discuss the presbyopia. Okay, it happens because of the age-related impairment in the accommodation, impairment in the accommodation. That means of focusing on the near objects mainly, and as a result, all these images will form behind the retina. Okay, because I cannot focus, the images will form behind the retina. Okay, very importantly. Now, what happens is 4 things are there. Okay, one is the denaturation of the lens protein. You must remember all these things, what happening with the age, because this condition is happening in the old age, right? As a result of the damage to some fibers and the proteins in my old age, this condition is happening. Okay, so you will have a decrease in the lens elasticity. Okay, you will have a change in the curvature. You will have a loss of normal distantability of the lens, or of the lens with the age, and you will have the denaturation of the lens protein. Because of these things, okay, your lens cannot focus the image on the retina, and as a result, it will form the image behind the retina. The converging power of my lens is now lost, just like my hyperopia. Okay.
Yeah.
Now see, if the patient is a patient who is previously having the myopia, which means the light will be forming, will be converging in front of the retina, right?
Yes.
And now with the old age, the patient will have decrease in the converging power of the lens, and the lens and as a result the this image will start forming behind the retina in the normal patient, right?
Yeah.
If the patient has a myopia before and the light will be forming, this is my lens, this is my retina. If the light was converging in front of my retina, then due to the presbyopia, the light will shift on the retina as a result of old age, right?
Yeah.
And that will improve the eyesight of the patient. And this is another second side of the old age. Okay.
Yes.
So step one will give you a patient who is having a history of myopia, and then suddenly in the old age they have this, this improve in the vision, this improvement in the vision, and they will ask you why this improvement in the vision is happening. It is because of the age-related changes in the lens. That means a loss of lens elasticity, less, loss of normal distensibility of the lens, and the denaturation of the proteins. And not just that, they will ask you what other conditions can be happening due to the same pathology. That means they're asking what other changes can be happen due to the age. Okay, and those were the change in the reproductive cycles, change in the skin, changes in the eye, changes in the organs, CVS changes, and other changes they will ask you. So please note that this second sightness in case of a myopia patient is because of the age-related changes of the lens. That is the presbyopia. Okay.
Yeah.
Now, any doubt on these 4 conditions?
No, thank
No,
you.
thank you.
Now you have the cataracts. Okay, cataracts is nothing but just the opacification of the lens. Okay, you have the clear lens, transparent lens, but once the lens opacified, they cannot transmit the light through them, right? And because of this opacification, the converging power of the lens is also increased, and that causes the cataract. Okay, it is always a painless condition, generally bilateral if it is age-related, or mostly it is bilateral also, right? Because of this opacification or the whiteness of the lens, you will have a loss of red reflex. And what does this red reflex means?
Usually on ophthalmoscopy, we see a red reflex using that instrument.
Why is that red reflex? Not in the fundoscopy. In generally, if you click a picture, you will see the red eyes, right? Sometimes in the
because of reflection from the retina.
arteries and the blood. Okay, all this reflection of the blood. If the opacification of the lens occurred, then the this reflection from the blood can never happen, and that causes the loss of red reflex. Okay, you will have the glare, you will have a loss of vision. Okay, and that vision loss is especially at the night, because in the light you have this lots of light from the headlight of other vehicles, right? So that causes the glare and the decrease in the vision. Okay, the risk factors includes the age. Okay, because of the age related all this denaturation of the proteins, right? They can cause it. Smoking can cause the loss of the antioxidants, and that can cause the this oxidative damage to your lens. Excessive alcohol use, if you guys remember the sorbitol,
Yes.
that can cause a damage because of the excessive alcohol. And because of the excessive alcohol, you're also using all these NADPH, right?
Yeah. NADH.
NADPH or NADH. NADPH it was, I think.
Alcohol gets converted into aldehyde and acetaldehyde and then acid. So that consumes all the
Yes.
NAD plus, which gets converted.
It consumes all the NAD as well as NADPH, right?
Okay, okay.
NAD will be converting into the NADH, and NADPH will be converting into the NADP, right?
Okay, yeah.
Because of this loss of NADPH, you're having this oxidative damage, and that again can cause a cataract. Because of the excess of sunlight, you have the UV rays, and UV rays can damage the lens, that can cause the cataract. Corticosteroids use, if you guys remember the side effects, it can cause the cataract at a very early stage. Diabetes mellitus, because all this glucose will be converting into sorbitol, right? Because of the sorbitol dehydrogenase, aldose reductase, right? You can have a damage because of the diabetes also. Trauma can do that. Infection can do that. Other metabolic conditions, if you guys remember in the childhood,
Galactosemia,
galactosemia
Galliput deficiency.
and the fructose also.
No,
Yes.
probably fructose
Yeah,
wasn't causing.
exactly. Fructose won't cause it. Okay, it's only the galactose that can cause it. Okay, good. So yeah, infection, trauma, metabolic changes, okay, diabetes, corticosteroid use, excessive sunlight, alcohol, smoking, and age. These are all the risk factors for the cataract. Patient will always present you with the loss of vision and having this glare in their eyes. Okay, and yeah, other risk factors include trisomies 13, 18, 21. All of three trisomies can cause a cataract. Torch infections, if you guys remember the
Yeah.
rubella can cause the congenital cataracts. And what other conditions rubella can cause?
Hearing loss and pulmonary artery stenosis and PDA.
Yeah, PDA, hearing loss, and the cataract. These are the classical triads seen in the rubella syndrome. Marfan syndrome can cause it because of the lens subluxation, if you guys remember. Alport syndrome can cause it. And what this is, Alport syndrome is?
Damage to the collagen type 4.
Collagen type.
Exactly, right? And it is a X-linked dominant or recessive?
Dominant.
Dominant disease.
Dominant.
Myotonic dystrophy, if you guys remember, the most common presenting complaint of the myotonic dystrophy is a cataract, if you guys remember.
Yeah.
What was actually happening in the myotonic dystrophy? The pathology behind it? No one? Because of what genetic changes myotonic dystrophy is happening? Trinucleotide expansion repeat.
Yeah.
And for trinucleotides?
EGT.
CTG.
CTG.
Yes, CTG. Okay, you will have the cataracts, you will have the baldness, you will have the testicular atrophy, and you have one more important syndrome. What was symptom? What was that?
Dilated cardiomyopathy and balding.
What? Please speak it again. I couldn't hear you.
Dilated cardiomyopathy and balding.
No, that's not in the myotonic dystrophy. The decreased relaxation of the muscles, right?
Yeah,
So
they'll not be able.
once the patient holds something, they cannot be able to relax their hand, right? While shaking hands or while holding a doorknob, right? They have difficulty relaxing. Okay. So do remember all these features of the myotonic dystrophy. Neurofibromatosis type 2 again can cause the cataract. Okay. And the pathogenesis includes the photooxidative damage, osmotic injury, and the nuclear sclerosis, which means the forming of new epithelium on the cortex. You have the cortex of the lens, and the inner stroma of the lens also, and that is the ophthalmology stuff. So we don't need to go into much deep. So that was about the cataract. Any doubt? Do remember the causes? Do remember the symptoms? Okay, and these are all the two things you must remember. Any doubt on the cataract?
No, thank you.
No, thank you.
Okay, then you have this aqueous humor pathway. Okay, so I told you that the ciliary bodies, okay, which are the middle part in your ciliary muscles, okay, just give me a second. Yeah. Okay. So I told you you have the ciliary muscles, and in the center you're having the ciliary bodies. These ciliary bodies will form the aqueous humor. And does anyone know how the aqueous humor formed by the ciliary bodies?
Filtration, hyperfiltration.
By the hyperfiltration of the blood, right? So when the ciliary body forms the aqueous humor, it first travels in the posterior chamber, right, which is behind the iris and front of the lens. Then from the iris, it comes forward like that, and from the pupil, it enters the anterior chamber. Okay. Then you have the angle of the eye, which is the angle between the cornea and the iris. And the maintenance of angle is very much required, because if the angle closes, the trabecular meshwork closes, and as a result, this the aqueous humor cannot gain access to the canal of Schlemm, and as a result, the drainage of the aqueous humor will be decreased. So the maintenance of this angle is very much required. Okay. Then after it enters the anterior chamber, it has two ways. Okay, one is the uveoscleral outflow, in which this aqueous humor directly absorbed in the episcleral the vessels in the sclera. Okay, and then you have the canal of Schlemm, okay, which is connected with the episcleral vessels, and it will be absorbed there. Right, two pathways. One is the trabecular outflow, and second is the uveoscleral outflow. The major pathway is the trabecular one. Okay, now let's discuss the glaucoma. In the glaucoma, you're having an increase in the aqueous humor in the eye. Okay, and this increase in aqueous humor can be due to two things. One is the increased secretion by the ciliary bodies, and second is the decreased flow by the this decreased drainage by the trabecular outflow or by the uvascular outflow, right?
Yeah.
Now you have certain drugs that can act on these bodies and these flows to decrease the aqueous humor production. Okay, first you have the beta blockers. The function of the beta blockers is to cause a vasoconstriction, right?
Yeah.
Okay. So whenever I stimulate, whenever I inhibit the beta receptors, I will have this unopposed alpha actions also. So that causes the vasoconstriction, and as a result, the blood supply to my ciliary bodies will be decreased, and as a result, the formation of this aqueous humor by the ciliary bodies will be decreased. So the drug timolol will be help in decreasing the formation of the aqueous humor. You have the alpha 2 agonists, okay, that decreases the sympathetic outflow, and as a result, you will have a decrease in the formation of the all this aqueous humor, right? Third, you have the drug which is a carbonic anhydrase inhibitor, and this carbonic anhydrase is required for the synthesis for the formation of this aqueous humor. If this enzyme is inhibited, okay, I will have a decrease in the formation of aqueous humor, and that will be the acetazolamide. Okay, so acetazolamide, brimonidine, timolol, all these three agents can decrease the formation of my aqueous humor. Then you have drugs that can increase the drainage of my aqueous humor, and these are the muscarinic agonists. Okay, the M3 agonist drugs like the carbachol, pilocarpine, they will increase the canal of Schlemm drainage or the trabecular. Actually, they will clear the trabecular meshwork so that the increase in drainage could be there. You have the prostaglandin analogs, okay, like the uh, atanoprost or the bamatoprost. Okay, they all have this prost in their name. They will increase the uveoscleral outflow, and as a result, decreases the this aqueous humor in the eye. Is that okay up to here?
Yeah.
That was about my aqueous humor. Now let's come to the iris. Okay, the iris is kind of a muscle. You have two receptors on this iris. One is the alpha 1 receptors, and second are the muscarinic receptors. Okay, the alpha 1 are supplying the dilator pupillae muscle. Okay, and the muscarinic receptors are supplying the sphincter pupillae muscles. Okay, whenever the dilated pupillae muscles contract, they will dilate the pupil, and whenever the sphincter pupillae muscles contract, they will constrict the pupil. Okay, so with the alpha 1 stimulation, I'm having a dilation, and with the muscarinic stimulations, I'm having a constriction. Okay,
Yes.
so tell me, if you guys give a patient alpha 1 agonist or a muscarinic antagonist, you will have a pupil dilation.
Yeah.
So how can you differentiate between a muscarinic antagonist and an alpha 1 agonist drug? I'm giving a drug X to a patient, and I'm having this pupillary dilation. How can I tell whether it is a muscarinic antagonist or a alpha agonist?
Is it by detecting if the person is still having an intact light reflex or not?
Exactly. If the person is having an intact right reflex, that means I'm giving the patient alpha agonist. If they do not have any intact light reflex, that means a cycloplegia. In that case, I'm giving a patient muscarinic antagonist, because for the pupillary contraction, you need the this muscarinic receptors, right? If I inhibit these receptors, then I will get a dilation, but I won't get the contraction, right? No.
Yeah.
See, if I
Sorry, can you please repeat?
if I inhibit my muscarinic receptors, I can get a dilation, but I won't get the constriction, because for the constriction, I require the muscarinic receptors, right?
Yeah.
If I activate my alpha receptors, I will get the dilation, but because my muscarinic receptors are normal, I will still get the constriction.
Right.
And that is the difference between the muscarinic antagonist and the alpha agonist drugs. If I still can get the constriction, that means I'm giving the patient alpha 1 agonist. If I cannot get the constriction by shining the light, that means I'm giving the patient muscarinic antagonist. Okay.
Yeah. Okay.
So that's all about the aqueous humor pathway and this iris muscles. Any doubt?
No, thank you.
Now the ciliary body along with this iris, this complete structure is known as the uvea. So whenever I say the uveitis, that means there's an inflammation involving my iris and the ciliary body. Okay.
Yes.
Now let's discuss the glaucoma. Glaucoma is nothing but the atrophy of my optic disc. Okay, and that is happening because of an increase in the pressure within my eye, because of this increase in the aqueous humor production. Okay, because of this increase in the pressure, I will having a characteristic cupping. See, if you look for the optic disc, if this is my optic disc completely, okay, in the center you're having only the blood vessels. Like if you guys remember the anatomy, we have discussed in the center having blood vessels, right?
Yes.
So in the center you're having only the vessels, and in the periphery you're having all these nerves, right? So this is the actual part where the transmission of the nerve impulse is there in my optic disc. Whenever I have an increase in the pressure, okay, due to an increase in this aqueous humor, I'm having a cupping of this optic disc, and the central portion where the blood vessels are present, they will expand. And by neuro optic disc will become a rim-like structure, as you can see. If this is my normal optic disc, as you can see in the centers, I'm having a blood vessels. In the periphery, I'm having only the neural optic disc. Whenever the cupping happens, the neuro optic disc will become only a rim-like structure, right?
Yes.
So this is a cupping. It happens because of an increase in the intraocular pressure. Can I have this optic disc cupping in the papilledema because I'm having a pressure increase in the papilledema also?
No, because nerves are not getting damaged over there.
Exactly, because in case of my because in case of my glaucoma, I'm having an increase in the intraocular pressure. In case of my papilledema, I'm having an increase in pressure within the meninges, which are present in my this optic nerve. Okay, the eye will be absolutely normal. The pressure in the eye will be absolutely normal in case of my papilledema. Okay.
Yeah.
Okay. Along with that, you will also have the progressive peripheral vision loss. Okay, and the visual field defect can also be there if the condition left untreated. You will have two type of glaucoma. One is the open angle, one is the close angle. If you guys remember the angle between the cornea and my iris, if this angle is closed, I will call it a closed, or the narrow angle glaucoma. If the angle remain normal or open, I will call it a open angle glaucoma. This condition is associated with the age. It is generally painless because it is kind of a very much chronic. Okay, its primary causes is still unclear. It just happened with the age. The secondary causes includes a blockage in the trabecular meshwork. See, if my angle is open, but I still got a blockage in the trabecular meshwork, I can have the open angle glaucoma. and this trabecular mesh could be blocked by the uveitis, which means the WBCs. In any case of any vitreous hemorrhage, if the blood vessel got ruptured, the RBCs can block this condition, this meshwork. Okay, sometimes if due to any trauma, if my retinal detachment occur, I will get the retinal elements blocking the trabecular meshworks, and that can cause the open angle glaucoma. Okay, patient will be generally asymptomatic. Okay, this condition is because totally painless. It just is starting having these vision losses. Okay, and when they present to your department, you will test all these intraocular pressures and all these things, and they will know that the patient is having a glaucoma. By looking on the fundoscopy, you will see the cupping of the optic disc, right? You will check for the IOP, you will see the slightly elevated IOP. Okay, that's how you know patient is having a open angle glaucoma. Then you have the closed or the narrow angle glaucoma, in which the trabecular meshwork was absolutely normal. It's just the angle between the iris and my cornea is decreasing, and as a result, the trabecular meshwork is closing. Okay, it can be happen because of the primary and because of this the secondary cause. Primary cause includes the enlargement or the anterior movement of the lens, because you know that the iris is present in just anterior to my lens. If the lens move anteriorly like that, the angle will be closed between my iris and the cornea, right?
Yeah.
So as a result, I will have a obstruction in the normal aqueous flow, and I will get the fluid buildup behind the iris, pushing all this iris against the cornea, closing the angle again, impeding the flow of this this aqueous humor through the trabecular meshwork. Okay. The secondary causes includes the hypoxia and the retinal diseases like the diabetes mellitus, venous occlusions, okay, any kind of vascular proliferation, and they will all cause an increase in the pressure behind the iris, and as a result, the angle will be close between the iris and the cornea. Okay. You also have the chronic closure, that is, the angle closure is there, but the condition is asymptomatic. If you give a patient any kind of a drug that can precipitate this condition, okay, patient can have a sudden acute closure. So it would be a chronic closure patient will be a patient who's having any of this cause, any primary cause there, any secondary cause could be there, but this cause is very much chronic and the patient do not have any symptoms, but they have a very increased risk of developing the acute closure. Okay, it would be an asymptomatic condition. Optic nerve damage happens at a very chronic rate, at a very slow rate, and as a result, the patient only have these vision problems, no pain. If you give the patient any any kind of a any kind of a agent that can precipitate this condition, like the atropine, for say, right? In that case, you will have an acute closure, a sudden buildup of the pressure will be there, you know, in your eye, and you will have a sudden vision loss. Okay, angle closes very abruptly. You will have a very painful condition. Red eyes will be there, as you can see. This is a redness of the eye, the conjunctival injection, you call it. Sudden vision loss will be there. Halos will be seen, colored halos. It would be frontal headache will be there, and you will have a fixed and the mid dilated pupil. Very example, this pupil do not react to the light. It is fixed and very mid dilated, not the extreme dilation. A middle dilation will be there. You will also have, because of this headache, you will have a nausea and the vomiting, and it can happen because of the mydriatic agents, and that's why the mydriatic agents are contraindicated in case of closed or narrow angle glaucoma. Is that okay?
Yes.
Yes.
So that's about my closed or narrow angle glaucoma. So for the treatment, you cannot give the mydriatic agents. That means those agents which is stimulating my alpha receptors, right?
Yeah.
Yes.
So I need to give the patient these cholinergic agents that can stimulate my muscarinics, like the pilocarpine or the carbachol. I can give the patient prostaglandins. I can give the patient beta blockers, but I cannot give the patient alpha agonist or the muscarinic antagonist. So it would be a patient who is having a very chronic history. I mean, you don't know at the time that the patient is having a history. It just, when you give the patient any of this agent, like any kind of any anti-allergic drug, because some anti-allergic drugs like the antihistamines, they have this anticholinergic properties also, right?
Yeah.
So by giving these drugs, or by giving any alpha-1 agonist, or by giving any atropine or any anticholinergic drug, the patient is starting suddenly having this acute kind of eye pain and headache and the fixed mid-dilated pupil, or this eye conjunctival injection, right? Halos, sudden vision loss will be there, and that's how you know that the patient is having a a primary or a secondary chronic angle closure glaucoma that now become the acute closure. Okay.
Yes.
And the vision loss will be peripheral vision loss, not the central one. Okay. The patient will be having a diminution at the peripheral vision. Okay. But the central vision will be absolutely normal. Any doubt on the glaucoma?
No, thank you.
Why is the peripheral out?
Yeah, ask.
Why is the peripheral vision loss?
Because of these optic disc changes, actually it's kind of a core ophthalmology stuff. You have some fibers running in the upward direction, running in the downward direction, and running in the straight direction. First, you have a damage in the upper fibers. Okay, actually it's not that much simple. It's not just a peripheral vision loss. You have this arcuate vision losses, and you have this then periphery, and then this central scotoma type thing. Most other changes are there, not just very much simple peripheral vision loss, but it is very much complex actually. Okay. If you look for the vision fields, this is your vision field, let's say. Initially, you have this loss in the upper field of the vision. Then you have this kind of a coma shape vision losses. Okay. Then this central vision loss will be there. And then this peripheral loss occurs. So, very much complex thing it is actually. Not as simple as it seems like peripheral vision loss.
Okay, thank you.
Okay. So for that, you need to go into the core ophthalmology. They will explain you better. Okay. Any more doubt on the glaucoma?
No, thank you.
So look for whenever you encounter a patient having a headache, eye pain, and you perform the this fundoscopy, you see this optic disc cupping. Okay, very importantly, and you will see the some mid-lateral pupil in a very acute case. In the chronic case, we have just this vision loss only. No other things will be there, right? Think about it and give the patient drugs. You have the uveitis, which is the inflammation of the uvea. That means my iris and my ciliary body. Okay. You have many type of uveitis. It could be anterior type. It could be the posterior type, right? The anterior type is known as the iritis, in which you're having only the inflammation of the iris, not the ciliary body. Okay. In case of my posterior uveitis, you're having a choroiditis. That means the inflammation of the ciliary body. Okay. Or even the retina. Okay. So anterior, posterior, you also have a middle this uveitis, in which you're having an inflammation of the iris as well as the ciliary body, but not the retina. If the retina is involved, you're having a posterior uveitis. Okay. These conditions can have the hypopyon, which means the accumulation of this pus in the anterior chamber, that is between my cornea and between my iris. Okay. You will also have this conjunctival redness, as you can see. Okay. It is associated with the systemic inflammatory disorders like the sarcoidosis, because I told you sarcoidosis can do anything. You can have the rheumatoid arthritis, it can do the uveitis. Okay. Juvenile idiopathic arthritis can do that. HLA-B27 associated disease can do that. And if you guys remember, the inflammatory bowel diseases can do that, right? And if you go for the seronegative spondyloarthritis, I told that reactive arthritis can also do that. Remember?
Yeah, yeah.
So reactive arthritis, rheumatoid arthritis, sarcoidosis, juvenile idiopathic arthritis, HLA-B27, all diseases can do that. Okay. So that's about the uveitis, nothing but just an inflammation of your iris and the ciliary body. And sometimes the retinitis will be there. You will have a vision loss, you will have acute pain, you will have this pus forming, and you will have this conjunctival redness. That's all the symptoms of the uveitis. Then you have this age-related macular degeneration. For that, I need to open a file. Just give me a second. Okay, so that's a age-related macular degeneration. It happens because of the oxidative injury to your retina. Okay, and oxidative injury can be happen with the old age. Okay, so that's why the name age-related macular degeneration. Okay, you're having the inflammation because of this oxidative injury. It causes an inflammation. You're having a subretinal inflammation. That means the inflammation just below your retina. Okay, and because of this inflammation you have some extracellular deposits, and the extracellular deposits in case of my AMRDs, it is known as the drusen. Okay, you're having the inflammation, you're having a deposition of some X28, you can call it X28s, and these X28s of the inflammation are known as the drusen. So you have two types. One is the dry macular degeneration, and second is the wet macular degeneration. In your dry macular degeneration, you are having a progressive, gradual vision loss. Okay, and the vision loss in mainly in the central vision because of this macula. See, all the changes you're going to see in the ARMD, it involves the central vision. The distortion in the vision will happen, and that involves the central vision. The loss of vision will happen, and that will again a central vision. So whenever you see a patient who is having a symptoms, okay, that are only limited to the central vision, the distortion, the loss of vision, the color changes, everything, okay, that means it is having a ARMD. On the fundoscopy, you're having the subretinal X28 deposits, and these are the drusens we have discussed. Because of the inflammation, you're having an X28, and that X28 will deposit in the subretinal layer, forming the drusen. It will appear as the yellow hard calcified deposits. You can see the pictures online on the fundoscopy of the drusens. It is a very, a very sharp demarcated kind of deposits you will see in the central part around the macula only, not in the whole retina, but around the macula. Okay, some soft cotton wool like spots can also be seen as a deposits. Okay, so both hard deposits and the soft deposits will be seen on the fundoscopy, and that's the dry macular degeneration. Okay, whenever the inflammation happen in your retina, you will always have the X28 formation. Okay, that can be seen in the retinitis, and they will always appear at the cotton wool like spots. If you guys remember, if you go back to the microbiology, we have discussed all these cotton wool like spots in the retina, right? In the torch infection, remember?
Yeah.
And these cotton wool like spots are nothing but the product of inflammation. Because of the inflammation, they're having a deposits of the X28s, and the deposits like the cotton wool like yellowish deposits. So that's the dry macular degeneration. Okay, and this you're having just the oxidative injury to your this layer, the subretinal layer, and because of that you're having a deposition. Now, once the deposits are there, they will cause the hypoxia. Because of the deposits, you're having the hypoxia, and whenever the hypoxia happens, you're having a release of VEGF, the vascular endothelial growth factors, and that causes the angiogenesis. And because of this angiogenesis, you're having a new vascularization. These vessels will become very leaky, and that will cause the hemorrhage. And because of that, patient will have a sudden acute vision loss. So it would be a patient who is having a progressive gradual vision loss up to a year, a old age patient, a central vision loss for up to a year. And now suddenly within 1-2 weeks, they have this kind of a very much progressive acute vision loss, a very severe vision loss. Think about the wet macular degeneration. On the fundoscopy, you will have a new vessel formation. You will see the hemorrhage, the reddish deposits on the retina will be seen as a hemorrhage. Okay, so these two things. Treatment includes a smoking cessation if the patient is any, zinc, which is an antioxidant type of electrolyte, you will give the patient. Antioxidants like the vitamin A, C, E will be given, and the anti-VEGF drugs like the bevacizumab can be given. That's about my ARMD. Any doubt?
No, thank you.
And that's everything what written here, the dry X28s and the wet X28s. Okay, wet can cause the rapid loss of vision loss because of the choroidal neovascularization and the bleeding, treated with the VEGF. Dry because of the deposits known as the drusens that causes a gradual vision loss, and that would be the around the macula only. See, similar kind of symptoms because this neovascularization, the hemorrhage can also happen in the diabetes, but in the diabetes it will be diffuse. But in case of my ARMD, it will be local. It will be localized to my this macula only. It will be clustered in the macula only. Okay, these kind of a hard X28s you can see. Okay.
Yeah.
And when they ask you where does a deposit kind of deposit, it will be the Birch membrane between the retinal pigmented epithelium. Okay, in between the Birch membrane and the retinal pigmented epithelium, these deposits will be there, right?
Yeah.
Yes.
So color changes, blurring, the straight line become very distorted. These kind of symptoms you can expect in the ARMD. Any doubt, please ask.
No, thank you.
No, thank you.
Okay. Yeah. So guys, I have to stop it here because I have an appointment with the ophthalmologist. So I got to go now. Okay.
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 Thank you so much.
Thank you.
Thank you so much, everyone.
Thank you.
for coming.
Thank you.
Thank you. I will upload the file soon. Okay.
Thank you.